Hello everyone. Today on this day we are starting a podcast for the pediatrician on the common topics. On 13th February 2025 we are going to celebrate World Anemia Day. On that occasion we would like to invite Dr. Viba Bafna and Dr. Lisa Bulsara, who are very famous hemato-oncologists from Pune, city of Pune. And we welcome Dr. Manoj Jhalte, President of Indian Academy of Pediatrics, and myself, Dr. Mahesh Sulakshane, Secretary of Pune IP 2025. So, first of all, what is anemia?
So, anemia is basically decrease in the oxygen carrying capacity of the blood. So, that is the physiological definition of anemia, but it means that decrease in hemoglobin. The commonest cause of anemia is iron deficiency and other nutritional deficiencies like B12 and folic acid.
How often do you see in your practice anemia?
Anemia is one of the commonest disorders, not just in Pune, India, but worldwide. The common age groups would be infants, followed by children from 2 to 5 years, adolescent girls, young females and pregnant females. These are the age groups wherein you will most commonly see nutritional anemias.
And over the period of time, how is the anemia incidence increasing, decreasing?
So, over the period of time, instead of having such medical researches and increase in lifestyle and a good quality of life products, we are seeing that we are actually decreasing in our quality of food. That's why from National Health Survey 4 to National Health Survey 5, there is an increase of 10 to 15% in anemia in all age groups. And we need to go back and retrospect why all this is happening.
Then we will go forward with how to diagnose the anemia.
So, anemia is first to have a high index of suspicions, that knowing that it is the commonest illness that you see and the commonest age groups. And second is if you clinically find the child to be pale, and if the parents complain that he is irritable, lethargic, has a low appetite, these are all the signs that the child may be anemic. And then there are non-hematological manifestations as in pica or breath holding spells or infant tremor syndromes. These are also signs of anemia.
What about school performance and other intellectual?
So, iron deficiency anemia, vitamin B12 deficiency anemia, the nutritional anemia also has a cognitive impact, and that makes the scholastic backwardness also. So, instead of just focusing on the physical elements, these are the neurological signs we will have to focus on. And though sometimes all anemias are not iron deficient anemia, and sometimes these signs and symptoms are the most prevalent signs and symptoms, and we need to address it properly.
So, commonly when the patient comes to your OPD and for other reasons, and you find out that the child is having anemia, because obviously that may not be your first point of contact with the patient, how would you like to go ahead with investigating this child, or you would want to start with the counseling? How do you want to go?
So, sir, the golden rule currently with everybody is that consider all the children coming to your OPD is anemic. The first thing is you have to have a very high suspicion index, and you will have to, even if it is coming for vaccination, that counseling has to be done, and then there is no harm in starting iron 2 to 3 mg per kg. If you find even a mild degree of anemia, if the HB you feel it is between 8 to 10 also, we can start it, because currently all diets are not iron fortified diets, and whatever we are making at home, it is not necessary the child is having the RDA, the required dietary allowance, which might not be fulfilled. So you can definitely start oral iron even without investigating the child if the suspicion of anemia is very, very high.
Dr. Viba, most of pediatricians would feel that hesitancy to start the medication because the parent would want to have an evidence of anemia. So would you in this case do some counseling or investigations?
So this is a very good question, and this is a purely counseling question. So when you have to take out 2 minutes, at least 2 to 3 minutes in your consultation to impress upon the parents the importance of iron in the diet. So iron is not just about anemia. Iron deficiency can cause so many other problems, and the most important, as Lisa has said, is neurocognitive defects. Let me tell you, and same you can impress upon the parents, is that anemia will get corrected. The hemoglobin will increase. But if your infant has been iron deficient for a good period of time, 3 months, 6 months, that is lost. and it has been proven by studies that the final neurocognitive performance of the child may lag behind his or her peers when compared. Iron sufficient child to an iron deficient child.
So early diagnosis and early treatment,
Yes.
even
And
before the child has kind of gone into
absolutely.
his
You
second year
don't-
of life,
absolutely.
you would
You
want to
don't
diagnose
need
this.
to wait for pallor or for your
To have the best
Absolutely.
neurocognitive
Absolutely.
outcomes out of this child.
Absolutely.
Okay.
I would say even a 1 milligram per kg of iron also works. It also works. Even if you don't give it daily, even if you just tell the mother, okay, you can give it 3 times a week. You can skip the entire week if your child is sick and restart it. Remember to restart it.
So we can explain that child to become more intelligent, more powerful.
Absolutely.
This is the best
This is the way to
Yeah.
counsel because all parents want their children to do well.
Yeah. Then what about the iron? How will you supply the iron?
So my formula is to just stick to 1 or 2 products that you like. So don't fall in for the trap of all the representatives that visit you and promise excellent results. So I usually follow giving ferrous fumarate in my practice. Give it for a prevention kind of thing, I give it at about 1 to 2 mg per kg per day. In the first year of life, I give it for 4 months. In the second year, for 4 months again. And again, in the adolescent girls, I give it for 4 months every year.
So every year 4 months, not continuously 2 years like that.
So since we are talking about the
No.
treatment, since we are talking
4
about
months is good enough. Yeah, sorry.
since you are talking about the treatment, what advices you want to give when you are kind of writing the iron prescription to the parents?
So advices which we give is have it in empty stomach, morning or night, whatever is feasible. You cannot combine iron preparation with any other medication, specifically calcium. So we try to avoid any medication combination with the iron medication. We tell them to give the iron or the syrup with a little later part of the mouth. The teeth staining is avoided. The GI complication in pediatric actually is not that much, but we tell the mother to be warned about the dark color stool or any constipation just for the check of it. So usually mothers, when counseled properly, do not come back. We tell them to follow this at least for a month. Come back with the CBC after a month to document the rise of hemoglobin. Continue for the iron stool replenishment 3 to 4 months as madam has advised as per the age group.
Okay, then I can add that if hemoglobin is not increasing by first month, then you have to
Yes.
find out the other.
Yes.
Causes of,
Yeah.
that's a very good
And for the
question you have to look for.
compliance, we tell them to come with the bottles.
Yeah.
Yeah,
Yeah.
just to see if it is regularly taken or not.
And then common scenario is we get staining.
Yeah.
So how to deal with staining?
Yeah, as discussed, we tell them to put a little later
No,
part of
if
them.
it is staining is there, you have to counsel parents that in long term there are no consequences.
Absolutely.
Yeah.
The staining is reversible.
Yeah.
Yes.
And a proper reasoning of the mouth after medication probably will
It
not
will
have
prevent the staining.
Yeah.
But most important thing is to counsel the parents beforehand.
Correct.
Because if you don't counsel them, they will be scared that why the stool is so
And,
differently
And they may stop
colored.
also.
And they will stop and they will not even come back to you.
okay.
So you will lose the patience.
Since we are talking about the management part of the anemia, what is the prevention, Dr. Viva? How do you want to
Yes.
counsel the patient about prevention of anemia?
Yes. So the prevention should start right from the pregnant mother. So mother has to be advised for a proper iron-rich diet, followed by early delayed cord clamping. So that definitely increases the iron stores for the baby. For a normal full-term neonate, you should start oral iron supplementation by 4 to 6 months of age. So basically for pediatricians, when they come for their third DPT vaccine, so that is the time you can introduce oral iron at about 1 mg per kg at that age, and then second year of life you again give it for 4 months. So that would be the prevention. Continue into the early childhood till about 5 years of age. And then again for your adolescent girls who are entering puberty, you give it for those 5 to 6 years, 3 months every year. Then the most important part is the nutrition part. So you must advise patients against all fast foods, highly processed foods like biscuits and chips and chocolates, pastries, bakery products. These are very poor sources of iron, and of course everybody knows that they're nutritionally very, very poor. So the iron-rich diet should be advised, which is main thing is the non-vegetarian sources of foods and the vegetarian sources of foods. So non-vegetarian sources are all very good sources except egg and milk, of course. And in vegetarian, all your green leafy vegetables and many other foods are rich in iron.
One more thing, what is the basis of giving iron during neonatal, like 2 months to start iron? Instead of even if breastfeeding is very adequate, so what is the basis?
So the basis is that the infants, their hemoglobin decreases. They have a physiological anemia by 3 to 6 months, and usually the iron which they are born with, as the baby grows, it starts falling short and not enough to support this baby's growth. So at about 3 to 4 months, even till 6 months, you should start supplementing iron. And other thing is that the weaning foods are poor in iron. All the weaning foods which generally the Indian diet is considered poor in iron.
Plus breast milk is also not a good source
Yes.
of iron.
And one more nutritional thing that I forgot was the breastfeeding. So breastfeeding, though it has less iron content, but its iron absorption is excellent. So breastfeeding we must always encourage first 6 months. And another thing is that not to introduce animal, cows and buffaloes milk till 1 year of age. So if you have to supplement milk for whatever reasons, you should advise them to take formula milk, because that will not hamper the iron absorption.
And one more thing is, because our culture is such that we give so much of emphasis of milk, but as per the guidelines, a child between 6 months to 16 months till 5 years of age is not supposed to have more than 2 small cups of milk.
Absolutely.
More than that, it is not just going to be stomach filling and non-nutrient source of the
Yes.
food, whatever he is having. And we have seen the growth and development getting hampered because of the faulty diet practices.
Absolutely. I must mention over here that there is an entity known as a cow's milk colitis, which is like a chronic ongoing inflammation of the intestines due to cow's milk. And this leads to the iron deficiency, in fact to the hemoglobin of 5 and 6 for many reasons. It causes micro amount of blood losses, chronic blood loss. It does not allow absorption of iron from other foods. Even if you give oral iron, but the baby is drinking liters of cow's milk by the bottle, your iron will not be absorbed. So if you have to treat iron deficiency, you have to stop the cow's milk, each and every drop, and then start iron.
Yes, thank you.
Dr. Lisa, once you have diagnosed anemia, treated it, given preventive measures, and even then you are not getting an appropriate result, what would be your next line of action?
So this starts from the diagnosis part. First of all, rule out why the hemoglobin is actually purely IDA, or it can be a Thal trait, which is very common currently in our population. So a simple Menzel index on your CBC will help you to start rectifying your steps from the first go. And even if it is not there, then we go deeper into the history. If it is an adolescent girl, if it is an early menorrhagia, or sometimes PCOS comes into early and we do the thyroid function test, USG abdomen. So basically, if you're still not getting a high at 1 month, probably this suspicion index should start at the 1 month of follow-up when you're not able to see a hemoglobin rise. Then you start thinking the pathological causes, or again reassess your dietary assessment if it is not happening properly, and the compliance part of it.
Yeah.
Mostly at this point of time, compliance will be your main issue.
So basically the compliance, the salt which you have chosen, whether the mother is giving it or not giving it, so these are still in the practice the commonest causes of non-rise of hemoglobin, because the counselling has not been and the follow-up has not been good. And then of course the next, as Lisa said, chronic blood loss is very important. So GI is your commonest organ from where they lose blood. So I would say something like a simple worm infestation. So that can lead to blood loss. So many things like that. There are whole list of causes, GI causes from where you can lose blood.
So in a nutshell, what is your 4 take-home messages for our pediatricians?
For our pediatricians, I would say prevent and diagnose early.
And every case is an iron deficient or a nutritional anemia case, and you will have to have very high suspicion. Even if the child is just coming for a routine vaccination, the palms should be checked, the early signs and symptoms have to be kept, and just not hemoglobin. Look at the other indices if you have a CBC report. Even the bold MCV and MCHC will be the first sign of high rise of early iron deficiency anemia, and we will have to keep the eye very, very open. The first thing is your eyeball for an iron deficiency anemia should be very, very prominent about it.
And I would like to end by saying that let us all join hands, and we are pediatricians, we are
Yeah.
responsible for the young generation who is going to be the citizens of our country, and we should make them healthy for the future.
And iron rich.
Thank you so much, Dr. Viva, Dr. Lisa, Dr. Manoj, for joining us on this session on iron deficiency anemia or a nutritional anemia, what we have discussed today. There are many much such more sessions are upcoming, and we would request all of you to encourage this podcast and circulate it among your friends, colleagues, pediatricians, and make sure that you are giving the best possible outcome of this podcast. Thank you so much.
Okay, thank you.